Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I am so pleased to welcome you all to the release of PCC's 2025 Evidence Report, Closing the Distance in Rural Primary Care. Evidence, stories, because stories are always very impactful, and solutions. And I'm thrilled to introduce you to the folks who are going to be joining us for this event. But I also want to call out the AAFP Robert Graham Center and the researchers there who are our partners in producing this report. In addition to myself, the other co-authors are Dr. Allison Huffstetler, who you will be hearing from shortly, Ann Kemsky from PCC, Jianyang Park from AAFP Robert Graham Center, Melissa Filippi from the Graham Center, and Melanie Langa from the North Olympic Healthcare Network. I also want to very much thank our reviewers who strengthen the report with their comments, and they come from a lot of diverse perspectives. Merritt Felsen, who you'll be hearing from today as one of our panelists, Dr. Blanca Frogner, who is a researcher, Dr. Randall Longnecker, practicing primary care clinician, family medicine, and also a researcher, and Dr. Monica O'Reilly Jacobs, a nurse researcher who will also be joining us for the conversation. I also want to communicate my deep appreciation to the American Board of Family Medicine, who have made this report possible and the release of this report. We very much appreciate our partnership with them. Dr. Warren Newton will be moderating a panel, and Dr. Newton has a lot of experience in rural primary care, is a researcher and leads the American Board of Family Medicine. We're going to first hear from Allison, who will provide high-level overview and main takeaways from the research. Then we'll have a reactor panel where we'll discuss the impact of the findings and what they mean. And finally, I will tee up the policy recommendations that are in the report, and then we'll hear from a panel to discuss those policy recommendations and recommendations that they may have in more depth. Let me now turn this over to my co-author and first author, Dr. Allison Huffstetler. Allison. Oh, you know what? Let me just also underscore Allison's bio as she's getting on the screen. She's the medical director at the Robert Graham Center and continues to practice family medicine at the Fairfax Family Practice. In her research capacity, she's very focused on really how to inform policymakers about primary care research so that they can put policies in place to strengthen primary care. Over to you, Allison.
Thanks so much, Anne. And it also helps me get away with my background, which I come by naturally as I'm in clinic today. So thanks so much. I'm really excited to talk to you all about this report. And I wanted to start off with two overarching themes before I get into the legislation, background, quantitative results, and our case studies. And that is, rural primary care during my presentation might sound like it's having a really hard time. But something that we found was that it's also incredibly strong, and that the relationships that exist within rural primary care are key drivers of why the rural community has not done worse than it has in terms of comprehensive care and health outcomes. There are really strong bonds in rural communities that keep primary care focused. And the other thing, as I discuss some of our results, is that this report is pretty expansive. It does not include all of rural primary care. But what I'm going to talk about during our time together today is not every finding from the report. So if you have more interest, please open it up from more than just the executive summary, take a peek at what we have, or look into our appendices that are full of a wealth of knowledge. All right, so we'll jump into the legislative background, if you don't mind, Todd. So we started off with an evaluation of the last 10 years of legislation that might have impacted rural primary care. And we did this in effort to drive how we went through and evaluated our background literature. We wanted to connect the two in a meaningful way because really what we're trying to do is impact legislation that will have a positive outcome for primary care in rural communities. There were over 48 legislative bills that were passed during this time period that had a general impact on rural health, and you can find them all in our appendix, but we concentrated on 5 that had the largest impact, and I'll talk about a few today. If we go back in time 10 years, the Medicare Access and CHIP Reauthorization Act, a acronym within an acronym if you're following along closely, was a huge impact for primary care in general and for rural primary care. This $175 billion legislation really gave financial stability back to clinicians who had had to deal with significant changes in reimbursement rates. The merit-based incentive program, of course, was introduced with MACRA, which changed the way that we measure quality in all settings across primary care. And MACRA also encouraged a change to alternative payment systems. But a lot of the administrative processes that came along with MACRA fell heavily on rural communities and rural practices that weren't prepared for the administrative impact of MACRA. Of course, the American Rescue Plan saved practices during the COVID pandemic and had a really sustaining and fulfilling purpose. And then if we jump forward to HR 1, I do want to highlight the impact of large Medicare cuts and changes on rural primary care. Rural practices rely heavily on federal funding, and the $1 trillion CBO estimates of what might be lost from HR 1 will have an impact on the sustainability of rural practices. And those estimates are maybe and maybe not offset by the rural health transformation funding that's also available. Todd, do you mind moving me forward one more, please? We tried to collate our background literature into the same areas that we also had our legislation. So from infrastructure, workforce reimbursement, veterans health, telehealth, and comprehensiveness. If you look at our report, you'll see that all of the legislation falls into those categories as well, oftentimes more than one category, because legislation does not have a siloed approach, right? We have more than one thing going on. But when we collated that with our background literature from the past 10 years, we see that infrastructure is critical in rural communities, specifically community health centers funded by HRSA, rural health centers, and other federally qualified health centers. There has been a huge loss of independent practices in rural communities, unfortunately. And so without the infrastructure of those federally funded centers, there would be a dearth of primary care in rural communities. Workforce has been very challenging from the clinician and from the entire medical team. We find that the number of people in rural communities have lower access to primary care clinicians. And of course, insurance coverage often dictates who they can and cannot see. For training, the National Health Service Corps and teaching health centers have had a wonderful positive impact on those communities. Teaching health centers have really demonstrated that when you train people in a community, they stay in that community. Of course, we're going to dig more into reimbursement as we move along today, especially with our case studies. But value-based payment has been a challenge for rural primary care to adopt, and that's because they don't have the same systems that urban and suburban centers have. Veterans, and I wish I could concentrate more than this, but veterans now have access to primary care through the Mission Act outside of veterans' health facilities. Telehealth, when available, is fantastic. Communities that lack broadband really don't have the opportunity to engage in this wonderful resource that connects them with specialists. And finally, our comprehensive primary care colleagues are doing a lot. They are expansive in their scope of services provided. Todd, do you mind moving me forward? Thank you so much. So let's jump into some of our quantitative results from this study. We looked at several aspects, and I'll focus on 2 here. So comprehensiveness is the first, and we use a refined score called BEDOS that includes where you are providing your care and what kinds of care you are providing. And what we see is that rural primary care, here in the teal color, has consistently provided more comprehensive services, both in their scope and place, as compared to urban settings. However, and very importantly, this has trended downwards over the course of time, and we see less and less comprehensiveness over the past 10 years. Go ahead and move forward. Thank you. And then we looked at primary care spend. primary care spend is measured in several different ways. For this definition, we looked at services provided by a clinician in a primary care setting. So this does not include lump payments for federally qualified health centers or CHCs. This is clinician-based reimbursement. And what we see on the left and right here are the two types of insurers covering spend. And in rural communities, you do see a higher percentage of rural primary care spend. However, that is also trending down over the course of time. What I'd like to point out is that in rural communities, if we're looking at clinician spend, there are oftentimes many fewer specialists. And because of this, the denominator, the full type of spend in those communities, is lower. So perhaps these communities measure at a higher rate of spend, 5.5% versus 4.9%, but in reality, the total spend in those communities is lower. Finally, we're looking at the percentage of primary care clinicians in rural communities. So this one's really important, and I want you to focus in on the numerator denominator that I'm talking about here. The teal lines are our rural communities, and the dark blue lines are our urban communities. And so if we concentrate on that first column for primary care physicians, what you'll note is that there's a higher density of primary care clinicians in rural settings. For example, in 2022, out of all of the clinicians in a rural setting, 34.1% were primary care, whereas the remainder were specialty. In an urban setting, only 25% of the total physicians were primary care, and then 74% were specialists. That follows for nurse practitioners, physician's assistants, and then if you look at the full scope of primary care clinicians, we see that in rural communities, there is a higher rate of primary care in these communities. So most recently in 2022, you see out of all of the clinicians practicing, nurse practitioners, specialists, primary care physicians, 36.4% made up in rural communities as opposed to specialists, whereas in urban communities, you had 25%. And then we'll jump into our case studies as a really valuable place to end because, like Anne said when we began, stories make this feel like a very full picture. So we interviewed 5 different communities and clinics across the United States. These were federally qualified health centers. They were counties and communities that had lost primary care. We spoke with one direct primary care. We spoke with a nurse practitioner-owned practice. And I'm going to summarize the themes that we came up with our case studies, and that is comprehensiveness. So think back to the first slide on our quantitative results. That was absolutely reflected in our case studies. In fact, during one interview, Dr. Filippi and I were talking with a doctor who was actively monitoring an OB screen beside him because he had patients in labor in the hospital right beside him. So the comprehensiveness that's happening in these rural communities is incredible. And oftentimes that is driven because of a lack of specialists or the significant travel time to get to those specialists. And I'll also comment that integrated behavioral health was the most commented lack of access within these communities during our case studies. Financial stability was also a really important part of our case studies. Having the ability to innovate and be creative outside of alternative payment models and value-based payment was crucial for these organizations, and many of them relied on 340B pharmacies for a little bit of extra income to keep that financial stability. And finally, workforce training and making sure that recruitment and case and training came into the community was essential. So finding local pathways, scholarships, training in situ, if you will, was key to keeping people in those communities to practice long-term, to be part of the medical care team, and to have knowledge of the community and what was most needed there. I don't think that's surprising. That sounds pretty intuitive, but it was absolutely reinforced that if you train there, if you work there, if you're from there, then you are far more likely to stay. And we have 2 fantastic examples of training in rural communities at the end of our case studies that I'd highly encourage you to look at. All right, Anne, I'll hand it over to you. Thanks so much for flying through some results with me. I greatly appreciate it.
Well, thanks so much, Allison. Tremendous presentation of a really comprehensive report with so much great quantitative and qualitative data in it. And so we will not be able to do justice to everything that's in the report, and we very much encourage you to download it and read it, or just read it on your tablet or computer. I think what we heard from Allison is primary care is doing so much, but with even a smaller workforce than their urban counterparts, and they're able to do that through team-based care and a very comprehensive primary care model. So we applaud that. We also know that HR1 we anticipate it's going to have some real effects on primary care. And so we'll talk about that during the policy section. Now, I'm so pleased to introduce our reactor panel and our moderator, Dr. Warren Newton. So please join me. First, I'd like to introduce Dr. Ryan Lashaber. He's an associate program director for the Waco Family Medicine Residency and editor-in-chief of the Waco Guide for Psychopharmacy and Primary Care. He is dedicated to full-spectrum family medicine, and he has many interests in global health, mental health care, addiction medicine, street medicine, and care for the underserved. Welcome, Ryan. Next, I'd like to introduce you to Dr. Monica O'Reilly Jacob. As I mentioned earlier, she's one of our reviewers. She's also an assistant professor at Columbia University School of Nursing. She is a nurse practitioner and nationally recognized nursing health services researcher who focuses on primary care nurse practitioner workforce. Hello, Monica. Thank you so much for joining us. Next, I'd like to introduce Bill Snyder. He's a principal at Levitt Partners, an organization that the PCC has worked with, and he in that capacity advised clients on matters related to healthcare coverage, the healthcare workforce, digital health, and Medicaid. Previously, Bill served as Medicaid director for the state of South Dakota from 2017 to 2021, where he led a team responsible for ensuring the state's most vulnerable people have access to medications and medical, dental, and long-term care. Welcome, Bill. And then finally, let me introduce our moderator. You've heard me mention him a couple of times, Dr. Warren Newton. He currently serves as president and CEO of the American Board of Family Medicine and the ABFM Foundation. He has previously served in many leadership roles. One I'll name, has worked with the American Board of Medical Specialties on strategic planning and many other task force, and was chair of the Improving Health and Healthcare Task Force. All right, Warren, I'll hand this over to you. Thanks.
Thanks very much. Thanks to Allison and to you, Anne. There's a lot of questions that I have, but I'd love to have very briefly the reactions of Dr. Lashober and O'Reilly Jacob and Bill Snyder to the report. And then I have some specific questions, and there's some questions coming up online as well.
Yeah, I'm happy to start on our end. Good to see everybody. Thanks for having me here. I greatly enjoyed reading the report. I mean, both from the breadth and depth of its review, but then also kind of the charge for primary care. And it's exciting to see the vision, continued vision for primary care, and really that it continues to be the hub in so many communities there. I think the thing that kept standing out to me over and over, personally practicing in a community health center, is just the key feature of community health centers being a nexus, not only of care, but as a community hub across areas. And I know we'll chat about that more, and I'm sure there'll be questions, but it's neat to see that central location of the community health center.
Good. Dr. O'Reilly Jacob.
I agree, Ryan. And one thing that I really appreciated of the report that I think is innovative is the attention that the methodologists played to really understand who the primary care nurse practitioners were and the physician associates. This is actually really difficult to do, to count those accurately, which of these providers are actually providing primary care. And they did it perhaps better than any other national report that's been published so far. So I really appreciate that.
Yeah. Ms. Schneider?
Yeah, I really appreciated the report, and I found as I read it that I was inspired by the clinics that were featured in the case studies and all the innovative and creative approaches that these clinics and others like them are bringing forward to successfully deliver high value primary care in difficult settings.
Great. Well, some specific questions for each of you, and then we'll open it up to the web. I think one of the lessons for me in the report is that rural primary care has to be comprehensive. And I'd ask you, Dr. LeShaber, and you, Dr. O'Reilly Jacob, how can we get there in terms of training? And also, where can we go with respect to comprehensive team-based care?
Yeah, I can kick off the conversation. I think, community health centers offer, on the physician side of things, just a fantastic training opportunity in the scope and mission for rural communities. I think what's really neat, as I've seen kind of the landscape, particularly in family medicine training, is when you look at different community health centers, whether it's a rural health center or an urban underserved FQHC, those settings often have an expanded breadth of training. And individuals leaving those training opportunities are excited about continuing to engage in that scope, that breadth of training in their future communities. Their future communities need that. They're eager for that. And that gives a lot of excitement for going to practice in rural communities. I'll use an example as, my current practice was one of the case studies, and we're a hybrid approach where we have both rural clinics and then also a central residency hub that's in a more urban underserved community. And still 50% of our graduates of an urban underserved FQHC setting end up in rural communities in the future. And so I think there's a lot of excitement when you engage in an expanded training model to really exercise those skills in a community that absolutely needs it in the future.
Yeah. So where you are trained becomes a really critical issue, and how you trained. Dr. O'Reilly Jacobs, from a NP point of view, what's your answer?
Well, I can piggyback on that, certainly. I think that was a theme that we heard from Allison too. So it's really essential then that we're partnering with the universities, especially for nurse practitioners in the local communities, and connecting them with preceptors that are in rural communities so that NPs are being trained in rural areas, and that there are postgraduate opportunities available to them, relatively locally as well. We have this new movement towards postgraduate training and fellowships for nurse practitioners and other disciplines. And it enables additional training, additional support in often very under-resourced areas and underserved communities. And they've had pretty profound effects across the country, but they certainly need additional federal funding to continue to support that growth.
Great. Thank you for both of those answers. I think I'd like to turn to headwinds against rural care, primary care. I think as I think about it, rural care was the canary in the coal line. The mortality and life expectancy began to drop in rural communities way before it started dropping in the United States as a whole. And yet now we're facing increasing headwinds, not the least of which is House Bill number 1, and as well as the baseline high prevalence of chronic disease and reliance on Medicaid and Medicare funding. Mr. Snyder, what's your take on this?
Thanks, Dr. Newton. Yes, you're right. The report identifies a number of headwinds, and there are even more out there, I think, such as you mentioned, HR 1 and its impact on Medicaid coverage. The report notes that payer mix is critical for sustainability of rural primary care practices. And that's one of the things that practices will have to navigate, right, is the reduced Medicaid coverage in a lot of cases as the Medicaid provisions of HR 1 begin to be implemented. So one of the things that can be done is within the Medicaid program as it remains, making sure that reimbursement is reviewed frequently and remains adequate for the cost that these clinics see, and encouraging also commercial insurance and employer-sponsored coverage to likewise invest in primary care in rural settings through overall reimbursement and other ways.
Yeah, I mean, I guess the question for me, having had a lot of chicken dinners in small rural communities, who are the partners? Because both educationally for both Dr. Schreber and Dr. O'Reilly Jacob, but also other kinds of partners that rural communities can seek out in this setting. And that's a jump ball for all three of you.
I'm happy to jump in some and start the conversation there too. I mean, I think partners in two ways, both in the long stream and the short stream. And I guess what I mean by that is the long pipeline for health in a rural community starts for individuals that are going to be the community nurses, the community clinicians, the community phlebotomists. That starts in elementary and middle school. I mean, pipeline programs work. I think that was highlighted in the case studies. That's highlighted in application after application I get to read for residency application. Pipeline programs work. And so I think the community partners, I think Monica, you brought that up across the schools and even further on in schooling. I mean, those pipeline programs work, and continuing investment in them really matters.
Yeah, I would add, the importance of care coordination in these communities because, with such a limited, actual clinician workforce, we're really reliant on people that are in the communities from, the senior daycare centers to the schools, to all kinds, social workers, all kinds of people that are out in the communities that can have tabs on what's going on with these patients, and help coordinating with transportation issues to access specialty services that are likely much further away.
Yeah, I'll comment that there's also probably a key role for state-based interventions. There's huge variability across the state, but offices of rural health can make a big difference. AHECs vary a lot from state to state, but can make a difference also in terms of supporting and helping that coalition. I think a final question along these lines is, again, for you, Dr. Snyder, and others, is that the way I read the report, the value-based care is a promise and has been helpful to primary care, but the report also suggests that rural practices have been less able to do that, to use that source of revenue. What are the reasons, and what can be done about that, do you think?
Yeah, great point. And of course, the report notes some ways that value-based programs could be made more rural friendly, from being thoughtful about benchmarks, timeframes, and the populations as being served. But also, we know clinics in rural communities oftentimes don't have the same capacity or capital to implement and sustain value-based programs. So really, it's the whole design of the programs needs to be undertaken with rural needs in mind.
Could you give an example, I think, for the audience, because you know this area really well, and that would be helpful, I think, for the audience.
Sure. So one example that we read about in the report even is the time frame for measuring the value that's brought by value-based care providers, primary care settings in this case. So for example, a 1 to 2 year time frame that might make sense in an urban setting may not measure the full value of the care and the services, especially the comprehensive nature of the services that are brought to bear in our rural communities.
Yeah, that's a great example. Any from Dr. Lashover or Dr. O'Reilly Jacobs? Any examples? I mean, financial viability of the practices is sine qua non. If you're not financially viable, you're lost. So, any reflections on that piece?
I think value-based care and team-based care are so closely intertwined, and thinking about who is involved in the team in a rural setting is so different than an urban setting. And also who is even a billable, who is a provider that can bill services even in a community health center setting is so different than in an urban setting as well. And so I think thoughtfulness of building a team that is consistent with the rural community is crucial.
And by consistent, you mean members of the community, but also with the force mix that you can support in the community?
Yeah, absolutely. Absolutely.
Yeah. Good. I got a question from the chat, sort of building on the comment of other resources. What's the role of local businesses? One of the challenges of the last 10 years is that Amazon has hollowed out the small businesses that often supported rural areas. chambers of commerce, other sorts of things. And I'm curious, examples from your case, Dr. Lefebvre, or others about other resources.
Gosh, that's a great question. I mean, I think the thing that I go back to, and maybe others will have more specifics, is health is so much more than what we do in an exam room. What we do in an exam room is 20% of a patient's health. And their access to jobs, the socioeconomic factors, their physical environment plays such a substantial more impact than whatever I could do in an exam room in a 15 to 30-minute appointment. And so continuing to support the health of the community, the financial support, the access to job status is crucial as well. I'm curious if others have specifics as well.
Well, I know of some nurse practitioner owners in rural communities that have partnered with local businesses to offer occupational health services. So we know which can establish a primary care relationship and be led forward for longer than just that visit.
Yeah. No, and then to that point, I know now there's some questions online that I'll put in is part of what we're trying to teach in these settings is collaboration and team-based care.
Mm-hmm.
What do you see as the promising, what is happening in order to teach those collaborations, Dr. O'Reilly Jacobs, or in the setting of your rural training sites, so on? How can we teach this?
I think it's exposure. I think it's really important that we're all witnessing how different disciplines practice. And we do that, through shadowing as a student, through preceptors, through co-managing. And you start to learn different ways that different disciplines practice and what they can offer those patients, and how as a collective, we really are, much greater as a whole than we are individually.
So if I'm understanding your bio correctly, you've actually championed getting nurse practitioners into rotations and into settings like that. Could you explain a little bit about that?
Well, I can say that I was graduating as a nurse practitioner from my graduate program. I went and worked at a community health center, one of the first that was a postgraduate program. So about half of my attendings were physicians and half were nurse practitioners. And I rotated through different specialties. And in that way, gleaned extra training in a very under-resourced rural community, and felt much stronger then after those 2 years of additional training to move on to practice on my own, and brought all of those skills with me.
Sure. So that's an example.
Mm-hmm.
What are you doing with your FQHC residency, Dr. Lefebvre? How do you train team-based care?
Yeah, it's got to be experiential. I mean, nobody's going to walk away from a 1-hour PowerPoint presentation saying, I'm ready to do this. It's got to be baked into what we do, almost in like a Montessori method, where you're living and breathing in team-based care, and you walk out and this is the practice you know. And of course, then you've got to know how to adapt that for different practice situations. You've got to know how to adapt that for a rural health clinic versus a just phenomenally researched suburban clinic. But the core tenets of how you work well, communicate well, designate well, operate top of license, all those core tenets have got to be something that you experientially learn throughout training programs.
They live it and breathe it.
Yeah.
And Dr. Schneider, love your thoughts. I mean, the other issue is keeping practices vital. Can you comment? And well, some of that is value-based care, but it's also the blocking and tackling of business. Is that an issue? Is that something we need to be thinking about as we try to support these practices in rural settings?
Yeah, it certainly is, Dr. Newton. And one of the things I was struck by as I read the report is all the important policy impacts on rural primary care clinics. The report points out a number of important policy recommendations, but even beyond those, there are those like Dr. Lashober alluded to, like the ability for all members of the interprofessional team to practice at the top of their license. That's critical for providing.
And presumably to be reimbursed for that as well.
Exactly right. Yes,
I hate to be cynical, but I think reimbursement is really important.
That's right. And that goes back to who are our potential partners, and the comment that, as you noted, our state agencies and state leaders are important potential partners in that way.
Yeah, so going back to the report, some basic questions, and maybe Allison, this is for you, Dr. Hofstadler, but just basic. What's the definition of rural? What are we talking about here? Just basic.
In our report, we defined rural as a rural urban continuum code of greater than 4, which is a really technical USDA designation of
RUCA, yes.
services available, right? So that's how we designate it for all of our quantitative analyses. We specifically reached out to clinics that had locations in those RUCA areas that were rural. And then in our background, of course, people define rural differently, right? This is not a one size fits all rural communities, and there are frontier communities, and there are even more rural communities. So it depends on the context, but for this, we used RUCA for our quantitative results.
Sometimes I've said it's where the chief of the Senate lives and whether they think it's rural, but that's a separate definition. So what about, Allison, the distribution and mix of providers? You have elegant work on the ratio and the percentage, but can you comment about what a team should consist of and if there's any leads from the data?
Okay, so what should the team look like? I will leave to the panel to decide. But what does the current team look like? I think we have an okay picture of that. And one of the perhaps somewhat misleading images that I presented was that workforce picture. And what we see is that of all clinicians in rural areas, there still are a preponderance of physicians in those areas, with about a third of which are nurse practitioners, third proportionally are nurse practitioners, and maybe 5 to 10% physicians associates, a much lower proportion of those. Now, does that compose the whole team? And I would say no, absolutely not. It's exceedingly challenging for us to identify non-billing clinicians or non-billing members of the team within the workforce. So those behavioral health professionals, they are hard to identify, but a key part of the team. MAs, RNs that are stable, those are people you have to have working to the top of their license, like Dr. Lasheber said, who are able to provide input, care for the patient on a longitudinal, continuous basis. And we don't have those data from this larger study. There are some states that have done a great job with this, Colorado specifically, Virginia, who have looked at the team members who provide those collaborative networks and do a great job at providing great health outcomes.
Yeah. So I think another question that's come up with the audience is, what about the other community health structures, the pharmacy, and other things? Do you have data? Do you have directions about that? Because obviously the clinics are only a part of the answer.
I would anticipate that most in this audience know that rural hospital closures is a large problem. And we can't silo primary care and say how wonderful we are, we can fix the problems of rural communities. That's not realistic, nor do I think anyone who has interfaced with the medical system would say that's possible. So hospital closures are a huge problem, and that certainly came up in the data. Pharmacies serving as local adjunct that would assist with patient care are valuable. Now, retail pharmacies have mixed results in that. And of course, you see lots of the Walgreens and Amazon, those larger contenders have struggled to stay in business and have not stayed in business in rural communities. But that's what the literature shows as of now. But I'm interested in hearing the group on what other what does this look like as a community rather than just a practice?
Open it up to the others of you.
Yeah, I think we also would be remiss if we didn't note the importance of oral health partners and members of the interprofessional team, community health workers we haven't had a chance to talk about yet, but they can extend clinics and get out into the communities where people need services.
Well, just to have one more question for the group, because it's a burning issue, is the deserts. We all think of maternity deserts or OB deserts, but there are rapidly, growing deserts. The inability to care, you lose a rural hospital, you lose many things, including access. It's a tough problem to solve because there's elements of the hospital, there's elements of the providers and whatnot. Your reflections, and there may be some policy issues we'll get into later, Allison, but how should we think of deserts? How should we think about solving deserts? Because it's not just the providers, it's not just the hospitals, it's also about in community infrastructure. Any thoughts about that?
A comment or a question came for us as well about whether or not there's the right proportion of clinician to population. And that is a question I think we have yet to see demonstrated with high quality evidence. And many smarter people than I have attempted to make a model based on patient complexity, patient needs, and identify what the right patient panel size might be. And we don't know that yet. And so I think for communities, there are some areas that have very, very few residents. And so do they need a full healthcare team with every single specialist? Absolutely not. They don't. And we have to allocate resources. Resources are not endless. And so finding that right balance, I think, is an answerable question, but we haven't answered it adequately yet. So I don't dare give you a number of this is the right way to put the number of people into a desert.
Yeah, I'll comment that we need to abandon the rhetoric that rural is backwater. Some of the most innovative care that happens is in rural area precisely because of the resource constraints. And I think that's one of the ways in which rural healthcare can teach us all where we need to go. So other comments about deserts? Obviously, some of you are in deserts and trying to solve deserts. I appreciate that, but other wisdom about where we can go.
I'd say in terms of the optimal ratio, agree with Dr. Hostetler that it's not known exactly, but we do know from the report that while about 20% of the country lives in rural areas, only 1% of graduates are going out into rural areas. So we know that's a problem. And I do think this discussion about deserts also brings us back to the importance of training clinicians in rural areas, because as we've noted, we know that that impacts where they're likely to stay and practice. So anything and everything we can do to build the whole pipeline from beginning to end helps prevent or eliminate deserts and kind of close the distance. And
we know from rural health services research is that if you come from a rural area, you're more likely to practice and stay in a rural area. And if you have a partner, that's also important. But we also know that at least half of the doctors and other clinicians working in rural areas come from urban areas. So it is possible to go the other direction. And I think it's about time to turn it over to you. And I want to thank the panel for a great set of participations. Thank you.
Well, thanks so much, Warren, for your fantastic moderation. And I'm glad that one of the themes that we tried to lift up in the case studies and in the rest of the report is about the incredible innovation that's going on in rural communities. And that in some ways, rural primary care is embodied a lot of what the National Academy of Science, Engineering, and Medicine calls upon primary care to aspire to, really comprehensive care, more team-based care, connecting to the community. It's not all perfect, but I think there is a lot of innovation there. And so I'm glad you picked up on that theme. I'm going to just review some of the policy implications in the report and then invite a group of policymakers to come and discuss those and other ideas. I mean, I think first, anyone who has been around the Primary Care Collaborative knows that we really hammer on this notion of primary care spending and its inadequacy. And so call upon federal and state policymakers in all of our regulatory letters and all of our interactions with state policymakers to measure what they are spending on primary care. And when we began that in 2018, there were about 2 states that were measuring primary care spend, and now there's 22 states. So we do feel like states are beginning to get the message that for them to have an appreciation of what they are doing to keep their population healthy, they need to understand what they're spending on primary care. And people continue to not understand this data. I mean, I was on Capitol Hill last week with staff from a committee of jurisdiction, and they had never heard that primary care expenditures overall are less than 5 cents on the dollar. They were astounded by that. We also know that patients don't know that number. A study that Dr. Andrew Bazemore did lifted up this data, and Kevin Grumbach was involved, and Rebecca Etz, finding that patients thought that the system was spending about 50 cents of every dollar on primary care, and they thought that the system should spend 60 cents on primary care. So clearly, this number is important to be tracking, and it's going to be really important to be tracking as states are faced with what do they do as the federal dollars for Medicaid start to be more constrained. And so we do not think that states should move forward to further cut primary care. We already are struggling with a rural population that has a higher prevalence of chronic conditions and who doesn't have the same life expectancy as those in urban and suburban communities. So these measures are going to be really important. The federal government has taken some steps. We want them to take more. We want all states to be reporting on primary care. We also believe that we need to be investing in those programs that have already proven their mettle. And, you know, I'll lift up the community health centers. The Congressional Budget Office did an analysis and showed how efficient and effective community health centers are, rural health centers as well. So, you know, as we think about the stresses that communities will be under as Medicaid cuts are put into place, let's make sure that we are sustaining and increasing funding to community health centers and rural health centers at the same time. I think I've made that third point, so I'll go on to the fourth. Just earlier this month, the CMS closed the application processes for the Rural Health Transformation Program, the $50 billion program that was legislated as part of HR 1. Those announcements of the selection for those proposals will be made by the end of the year. Each state will be getting an award. We are urging CMS to select proposals that really emphasize strengthening primary care. So, and we're going to talk to the head of the CMS Rural Transformation Fund in just a moment. We also, you heard how value-based models are really not taking off in rural settings. Under the last administration, a new model was introduced called Primary Care Flex. The PCC was very involved in bringing together 25 other organizations along with the National Association of ACOs to suggest to CMS that they implement this model, which pays primary care on a hybrid basis and does invest more in primary care within an ACO model. So, you know, and there's a focus on rural and CHCs for that model. And so we want to make sure that that model is successful. We'd like to think about a second tranche for that model. But what else can those who are proponents of value-based care do to really help get rural practices into value-based care? One thing that hasn't been mentioned so far is the bundled payment that was in the 2025 Medicare physician fee schedule rule and has been broadened in the 2026 fee schedule rule, the APCM, which is a prospective bundled payment to do a lot of things that primary care does, and either they don't get paid for or the juice is not worth the squeeze, you know, actually coding for some care coordination and the like. is really not worth it. So this new code, APCM, just started getting into place this year. We really hope that this is something that will be a viable way for rural practices to begin to get more predictable and flexible dollars and more dollars into primary care. So we're excited about the expansion and the incorporation of behavioral health into that code. And we think that is a really important thing to move forward. We'll also, I think, have a chance to talk about some of the policies related to training and education. And I think we heard a lot from the Reactor panel about the importance of training in rural communities. We know that the teaching health centers provide really effective training when they are training, and folks stay in those communities. And it is very cost effective and incredible training. We need to support that more and bring more folks into community health centers for that kind of training. So let me now introduce the panelists who are going to discuss these issues and more. First, I'd like to introduce Alina Chekai, and she's the director of the Office of Rural Health Transformation at the Center at the Centers for Medicare and Medicaid Services. She's a forward-thinking health policy and strategy professional. I'm waiting for her to join us here. Here we go. Hello. And has been focused on improving quality of care in rural settings throughout her career. We're very excited to have you here today and to hear your remarks about this exciting fund and where we hope it will take rural health. Dr. Lauren Hughes, the State Policy Director of the Farley Health Policy Center at the University of Colorado Medical Campus and co-chair of the National Academies of Science, Engineering, and Medicine NASM Committee on Primary Care. She previously served as Deputy Secretary for Health Innovation in the Pennsylvania Department of Health, still practicing, and has a lot of experience practicing in rural settings. Welcome, Lauren. Frank McStay is Assistant Research Director on the Healthcare Transformation Team at Duke-Margolis Institute for Health Policy. He's been at Duke-Margolis since its early days, and he's been a Senior Policy Advisor and Health Policy Advisor at Baylor Scott & White in Dallas, Texas, a fantastic provider group where he handled special projects, regulatory and legislative policy, spearheaded applied health policy research, and represented the system in several national and state associations. Welcome, Frank. And last, but certainly not least, and someone whose comments on the report were incredibly insightful, I want to welcome Merit Felsen. She's been involved with community engagement and community-based practice research for nearly 20 years. And many of us in the primary care space very much appreciate being able to work with Merit, who helps us to be grounded. You know, what is the North Star? Why are we doing any of this work? Is to really be much more responsive to what patients want and need in our healthcare system. She's worked with the High Plains Research Network and the Community Advisory Council. And this group informs, advises, and co-creates health research to strengthen primary care across rural eastern Colorado. We have 2 people from Colorado today. Isn't that exciting? Okay, well, I'm really looking forward to moderating this discussion and to your questions. Please put them in the chat. But before we get into more of a conversation across all of our fantastic panelists, I'm going to ask Alina if she would tell us a little bit about this new program, the Rural Health Transformation Program. A brief overview for the listeners who may not be aware of it, and what you can tell us about the applications, which just came in. And so, you know, maybe not much yet, but please.
Wonderful. Thanks, Anne. And great to meet you all. Thank you for having me. So as a bit of background, the Rural Health Transformation Program was authorized by the President's Working Families Tax Cuts Act, was signed into law in July 2025. And essentially over 5 years, $50 billion of funding will go directly to the states to help them improve healthcare access, quality, and outcomes through transforming the way care is delivered. So half of the funding will go evenly to all states with approved applications. So this means that if all 50 states' applications are approved, each state would receive at least $100 million of funding each year. I am pleased to share that all 50 states did submit applications. So right now, those applications are being reviewed for the required criteria, the necessary information, and then through the merit review to assess their applications. Other half of the program is competitive and really based on three general criteria. So first, looking to see individual state metrics around rurality and a state's health system, better understand their geography, population, what their rural health systems look like today. Second, currently implemented or commitments to state policy actions that enhance access and quality of care in rural communities. And then third, application details on funded initiatives or activities that reflect really the greatest potential for and scale of impact on communities. And essentially, the program is asking states to really transform their rural delivery systems around 5 strategic goals. So the first is make rural America healthy again. So this is your focus on preventative care, behavioral health, chronic disease, and the root causes of diseases. So this could look like health literacy programs, community-based programs, diabetes management, nutrition focus. The second focus is sustainable access. So really focusing on how do you provide the necessary range of healthcare services in an efficient and sustainable way? Very excited with this one to see different stakeholders, different provider types coming together and networks to keep care local and affordable. So this could look like a clinically integrated network or other initiatives, even like telehealth to keep care in the local community. The third initiative is workforce development. So as we've heard throughout today's conversation, this really is a significant upstream pain point for rural communities. And at CMS, we really believe we need to build a strong pipeline of local healthcare talent. We know that a strong workforce is really the backbone of rural healthcare and also one of its greatest challenges. So we're interested in seeing things like training programs, rural residencies, different pipelines for nurses and EMTs, all sorts of tools to even make their placements in rural communities easier. So short-term housing, potentially childcare help at times. The fourth initiative is innovative care. So really, this one's focused on value-based care, wanting to see models that help shift the system from one focused on volume, to value in ways that really accommodate the uniqueness of each rural community. And then finally, the fifth is tech innovation. So I know we'll have some discussion on this piece today, but in this fund, we're excited to help bring about technology in rural communities. So remote care services, consumer-facing tech, interoperability, telehealth. For so long, rural communities have really been left out of a lot of the technology conversations, with tech infrastructure and investment going to the big systems or where the funds flow. But you can make the argument that rural communities really stand to benefit the most from technology advancement. So we're very excited to see innovation from the states there. As I mentioned, all of the applications are being reviewed and scored by merit reviewers. So individuals from federal government, as well as non-federal reviewers. So experts, many in academia, many providers. My team is not conducting the review, but we have had the pleasure of starting to read the applications to see what's in them. And I'm very encouraged by the innovation, the thoughtfulness that went into these applications. And I'm sure many of you on this webinar played a role in contributing to those applications. So thank you for everything that you've done to support this program, and we'll be sure to make you all proud.
Well, thank you so much for that overview and for detailing the criteria, and exciting that all the states stepped up. I talked to one individual in Rhode Island who mentioned that, you know, the state collected a number of proposals, and from the state of Rhode Island, which I'll remind everyone is tiny, they had 300 proposals. So I think there's, you know, a lot of ideas, a lot of excitement, and you clearly went through the list of criteria. Just stepping back for a moment, for our community that's very focused on primary care, where does that kind of fit into, you know, this transformation program? How do you see it? Oh, you're on. I'm sorry. You're on.
Sorry about that. I would say primary care is definitely woven throughout the entire program. So first, you know, we know that in so many rural communities, a primary care physician or an advanced practice provider focused on primary care might be the rural patient's only connectivity to the healthcare system. So we have a number of initiatives that we're interested to see focused on, you know, helping those providers practice at the top of their license. You'll see a number of different licensure-focused state policy actions the states can consider. Also, a big focus on chronic disease management, prevention. Telehealth, I think, is another really important angle to consider from a primary care perspective. Again, with the focus on keeping the care for that patient local, keeping them in their community as able, and then connecting them maybe to specialists or others, you know, in a virtual setting. In reading the applications that have come through, I'm really encouraged to see a very big focus on primary care, as well as kind of other applications of primary care. So maternity care, you know, care for mothers and babies, aging populations, chronic disease. But a lot of those initiatives really are woven together through primary care.
We would agree with you. Okay, well, let's get the rest of our august panel into the conversation. You mentioned the importance of tech innovation. What we found through the case studies is that telehealth is not being taken up to the degree we would like, or that we perhaps even thought going in. I'm wondering, first, maybe I'll ask Lauren to kick this off, and then Merritt and Frank, please join in the conversation as well. Why do you think that might be the case, and what can policymakers do to try to encourage and incent more telehealth?
Yeah, no, thanks so much for the question, Anne. And, you know, as a, you know, a clinically active family physician in a rural FQHC, I will respond to your question primarily wearing that hat. And so I think about my clinic where I was all day yesterday and had telehealth incorporated in the midst of my in-person visits. And when it comes to telehealth in rural settings, there are three aspects that I think about. The first is the technical piece. So do you have access to high-speed internet and those sorts of things? And that often comes up in these conversations. So I'll put that bucket aside for the moment. The second bucket I think about is around cultural issues in accepting and using telehealth. I have noticed in my practice sort of generational attitudes toward telehealth that vary. And some of my older patients in practice, like if they talk to me on the phone or see me on a screen, do they really talk to the doctor? It's unclear, right? Like it really has to be in person for them to feel like they've been seen and heard and taken great care of. And then also digital literacy, and that is different across different generations in working with telehealth. The third bucket I think about is around care delivery, and I think within each rural practice setting, which is going to look a little bit different, And rural patient populations vary across, different rural and frontier settings. But I think that practice needs to have an intentional conversation about the right visit types, the right types of patients or patient visits for which telehealth makes sense. As I have done a lot more telehealth since the onset of the COVID-19 pandemic, for me, an ideal use of telehealth is to go and have an in-depth discussion with patients about their lab results, or to have an in-depth conversation about those vague symptoms that in a busy clinic day, when I see dizziness on my schedule, I get a little bit of pit of anxiety in my stomach, because that can be, it's just one of those sort of nebulous sometimes symptoms. And so having telehealth is a good opportunity to dig in there. In my experience in our clinic, telehealth for establishing care visits, not a good use initially of telehealth, but if you've had an in-person opportunity to establish that relationship, it can be a very useful modality afterward. So again, I think about telehealth in the rural setting from a technical perspective, a cultural perspective, and a care delivery perspective. So I'll stop there and look forward to hearing the rest of my colleagues weigh in.
Thanks so much. Merritt.
Yeah, Lauren, thank you for setting that up that way. I've been thinking about this a lot, and trying to kind of take my own view, but also this sort of wide population, patient perspective about telehealth. It's not that we don't have capacity. We do. We have the capacity. But the way I think about it is that this patient-provider relationship, and whoever the provider is that day, whether it's a nurse practitioner or the PA, or I get to see the doctor or the LPN, doesn't matter. My relationship, our relationship with those providers is at the core of the Venn diagram. Telehealth isn't. Telehealth is one tool to continue this really nice back and forth when appropriate. And what I know about my community and those I communicate with is that this idea of this relationship of whole person care is so important, and that relationship building is the nexus, that is the center, and that telehealth works when that's super strong, and that has been sort of fostered into, this is one important piece of how we can continue this really strong relationship. It is not the answer. It's just another tool. And so when I think about that relationship and I think about those important components around this relationship at the center, it's not just me, it is this relationship. I think about it is all the people in the office, all the staff in the office. It's the ability to make referrals. It's ability to see somebody in a normal amount of time. It is ability to get quick questions answered. And one of those is the ability to access the tools that I might need as a patient to sort of achieve my goal for the day. And one of the many tools, along with an X-ray machine and the ability to set my broken arm and the ability to maybe do an ultrasound and the ability to kind of test all these other things, test my labs, is to have telehealth as a tool. So yeah, that's how I think of it.
Thank you, Merritt. That was very important to remind us about the centrality of the relationship. Frank.
From my perspective, and just briefly to double down on a couple things, I think Dr. Hughes said, infrastructure, very much a case of telehealth. Like, there are absolutely kind of what I consider last mile delivery issues with broadband access that we still need to work on. That said, I think some of our learnings from COVID show that, even if you build it, some people aren't going to come. And that's because, to Merritt's point, like, we're still trying to figure out the spectrum of delivery and how best to engage patients. And so a few things that I think about trying to keep my comment solution focus in terms of, okay, how can we make sure that if it's there, we have appropriate access and that people are using it. And so from a policy perspective, I think, CMS has taken steps more recently in its finalization of the physician fee schedule to kind of broaden that ability. And so that means, they've removed some of the frequency kind of limitations around when you can use telehealth. They've tried to simplify when telehealth codes can be permanent or not. And so these all help from a fee-for-service perspective to kind of open the door, so to say, to practices to give some revenue streams for telehealth. But that alone isn't sufficient. I think where I go to is we need to move to more whole person payment models to kind of latch onto the whole person delivery models. And so I think of two things, again, we discussed this a little bit on the last panel, trying to make more on-ramps for rural providers to value-based payment options. And I think CMS is trying to do that through things like PC Flex. But I'd also point to things that we could potentially do through benchmark reforms to help get more providers in the game that are in rural settings. The second thing I'd comment on and really highlight is really, again, doubling down on some of Merritt's points about there's a spectrum of telehealth out there, but that doesn't mean patients necessarily always want that. I think something the report highlights is that, rural care is primary care, more so than perhaps urban. And that means that there is a strong physician-patient, clinician-patient team with a patient relationship there. And so I think the ways you can augment that and really empower patients through what CMS is doing through its Healthcare Payment Learning and Action Network, trying to understand from payers and providers, how are patients engaging, both with digital modalities and non-digital modalities. I think those all show that we're trying to touch different parts of this digital elephant a little differently to really understand appropriate telehealth use to support that kind of whole patient journey.
Yeah, and I want to double click. Merritt, were you about to say something?
I was going to make two more points, if I
Sure.
may, really
Yeah,
quickly.
please.
So I'm sort of in a border county. I am in Colorado, but Nebraska, getting to a clinic in Nebraska and or Kansas is sometimes actually easier than going to the Front Range where specialists are. Some of the licensures of those who are in my particular primary care offices do not transfer across state lines. So there's the limitation. And then I will say a plus for telehealth that the primary care individuals that I've spoken with say that it is really great to sort of to help coordinate transfer of care. So in all those situations where there's a lot going on and lots of loose ends, that is a wonderful place for telehealth.
This is such an important conversation because clearly we're going to continue to have innovation in the tech space. And obviously, now folks are thinking about, okay, how does AI figure into all of this? And I think that Merritt's point about the centrality of the relationship, I think we don't want to get that should not be lost in the conversations about all the fabulous things that AI can do to help reduce administrative burden, help identify and close care gaps, really take off some cognitive load from the primary care clinicians, which, they have a lot that they're dealing with. But what I don't think we want to have happen is that it is replacing that human connection and replacing or interfering in the ability of building that really important relationship. I was on a earlier meeting with some CMS officials, and the conversation turned to how do we incent outcomes that would be about the relationship, because we don't have any measures that are really incenting that kind of outcome. How might we do that? Because we know from all the research that when you have that kind of strong relationship, patients are more likely to make the behavior changes that are really going to help restore them to health. Put in place whatever the clinician says is the recommendation, embrace it. And really, it makes a difference in their care. So, that is something we want to make sure we keep our eye on with all of this innovation. And, I think Allina is going to see a lot of that in the proposals that come forward. So I just want to really highlight that. Rural health clinics and federally qualified community health centers are so critical in rural communities. The statistic is very high, I think, in rural communities. between a rural health center and a community health center, more than a majority will have one of those practices. I think it's up to 80%. So obviously, strengthening them is really important. What might public programs and even commercial payers do to strengthen these models that are so important to the community and that we've seen are also team-based and more comprehensive than you might find in other settings? So just put that question on the table, whoever would like to go first.
I can kick us off. So I think previously my comments kind of highlighted the need for on-ramps into these programs, value-based comprehensive primary care programs. I think something else that we talk about in terms of sustainability and reducing the burden for actually participating in the programs. Something that public programs and commercial payers could do that would really help multi-payer alignment. From a fee-for-service standpoint, like whether it be a HCPCS or a CPT, we kind of understand across the 10, 20,000 different codes out there what you have to do to get the reimbursement and to justify it. For value-based care, the permutations of subcap, primary cap only, full cap, just pay for performance, which quality measures really challenge any provider, but especially rural providers, kind of sustainability in these programs. And so when we think about from a multi-payer alignment standpoint, creating one model out there that allows kind of not just an on-ramp, but sustained pathways for participation for rural providers is really important. One opportunity through that might be something like a clinically integrated network, where a lot of robust state participation, where there's more kind of cross-state alignment and regional alignment from a payment model standpoint. I think the second thing that I'd really highlight here is—
Before you go to the second thing, can you make sure that everybody in our viewing here today with us, the 300 plus folks, understand what is a CIN, a clinically integrated network?
Yes, a clinically integrated network is basically the idea that maybe smaller providers in particular could kind of have one contract that they execute across different providers in different geographic areas to enter into a value-based arrangement with multitude of payers. And so a lot of people think it's ubiquitous with necessarily like market share, but it's really a simplification tool about simplifying the contract and making it easier, again, to get into value-based care and continual participation in it. And so CINs offer the ability to kind of execute those multi-payer arrangements or to ensure that there's less burden when you participate in value-based care generally. It's a very popular tool. I know Texas, for example, has a couple different CINs from a rural hospital standpoint as well as an FQ standpoint. The other thing I'd really just emphasize is the blending and braiding of funds. As we've kind of highlighted, rural health providers, FQs, survive on kind of the plurality of reimbursement out there. That includes both the direct reimbursement, but also the indirects coming from various grants or state programs that are out there. There needs to be a recognition from policymakers that if these location settings are going to survive, they need to understand how these different mechanisms that are reimbursing providers kind of all work together. Limit the duplication, diversify kind of the unique purpose of it, but have a vision in mind about how each of these funding streams really build towards, again, more whole person payment models.
Thank you for that. And maybe, Lauren, you want to jump in on that comment?
Yeah, absolutely. So, Frank, fantastic response. And there are a couple of additional sort of points I would make related to CINs and to value-based care in the rural space in general. I am doing a lot of work right now in Colorado in the rural and frontier hospital space, and there's increasing energy and interest around rural hospital CINs. And so, taking that idea and extending that to rural primary care as a way to improve population health, make it easier to participate in value-based care, but also to become more, have an opportunity to share resources, whether that's workforce, whether that's technology, be more competitive for getting better rates in contracts with commercial payers, for example. So lots of potential benefits, and a sentiment that I hear frequently in the rural hospital community as they think about pursuing and establishing a CIN is that this is a mechanism that allows these very valuable anchor institutions in these rural communities to remain independent through interdependence. And I think you could extend that sentiment as well to rural primary care practices of different types. The second thing I'd like to zero in on is where I think support and more research and other resources are needed to better understand the experiences of rural primary care practices that have ventured into the value-based care space. What was their experience? And also to explore with practices that explored doing a value-based care model and opted not to. What made them say no? And dig into that, because therein lies really rich information about what are the additional resources or different ways we need to think about innovation and value-based care in the rural primary care space that we might not otherwise. Some of these things have already been surfaced, I think are really important, including examining our benchmarks. What are rural appropriate benchmarks and timelines to achieve health outcomes or savings, if that's what you are going for in a particular model? Better data analytic infrastructure, and also practice facilitation for thinking about how to deliver care differently in a particular setting. But one of the things that, and this is the last point I'll make on this topic of value-based care, one of the things I often feel gets lost in these conversations when it comes to rural primary care or rural hospitals engaging in value-based care, it's often through a deficit-based perspective. What's not often surfaced and emphasized is that there are a lot of incredible assets in pursuing innovation through a value-based approach in rural settings. In my previous role in state government in Pennsylvania, I was responsible for helping to design and launch the Pennsylvania Rural Health Model. And there, working in those rural communities, appreciated that there's less red tape. That's a huge benefit in many of these communities, right? You see a lot of creativity flourish in resource-constrained environments. And in many communities, there's a lot of social capital, strong community bonds with entities that, yes, are focused on healthcare, but also the broader social drivers of health that you can really pull into these value-based care conversations. And I think if we're going to be talking about rural value-based care, we absolutely need to take into consideration the assets that many of these communities have. So thanks, Ann.
Yeah, well, thank you for that answer. So I think it's, the learnings can be bi-directional. And maybe, Alana, you want to get in on this conversation, please.
Oh, no, I was just really enjoying listening and hearing the remarks. You don't want to hear from the policy person on that. This is more interesting.
No. Well, I guess I just want to underscore what Lauren just said, because I think that we do need to have more bi-directional learning happening. How is it that team-based care is so successful in rural communities? What can rural communities teach perhaps primary care practices in urban settings about, how to have a successful team that is both patient-centered but team-based at the same time? How do you do that successfully? What are the training models to make that successful? How do you do that in practice? How do you incent a team? And what can the rest of primary care learn? I mean, I absolutely, my big takeaway from this report is about the assets in the community. And also, we in urban settings are often talking about or we're bemoaning that we don't really have community-based primary care to the extent we once had. And we're losing a lot of that connection to the community, and that's unfortunate. Well, it exists in rural communities. What can we learn perhaps about reestablishing those kinds of connections so that primary care can be a locus for connecting to the community to address these social drivers? So it does seem that there can be learnings across these different geographies, and that, yes, rural brings a lot of assets to the table. And I do agree with you. We have to be thinking about that, and also making sure that in a resource-constrained environment, which I think we're all concerned that we're headed towards even more so, that those assets are not further depleted. I think that's worrisome. Okay.
Can I make a comment there?
Please.
So the question was, what can the policies do to make sort of primary care in rural communities stronger? And so we talk about all these innovations and we talk about how primary care has become so comprehensive, and it's amazing. And I see that when I go. I'm so just like astounded by what our primary care offices and clinics are doing. But I have to tell you that underneath that, I have a real concern, not about their delivery of care. I think it's amazing and elevating all the time. My concern is that this pressure to be so innovative in order to stay alive is too much. It's too much. How can you ask someone to be the provider and a business person and an innovator and to continually sort of expand and add and navigate all these complicated systems in order to be sort of thriving and healthy? Why can't policy just simply make it easier?
Yeah.
I realize that's really simple, but that's my perspective. I want my primary care office to just chug along with the perfect amount of patient panel and to do everything that they need to do without having to constantly fight for sort of the next level of innovation in order to be more comprehensive, in order to get the next dollar so that they don't have to worry about next 6 months.
I have nothing to add to what Merritt just said. And this is why we love to work with Merritt and partner with her to speak to policymakers, because I think what you've said is absolutely right. Primary care clinicians in rural settings are 15% on a population level, 15% lower than in urban settings. So we really can't do more, to reduce that workforce. And in fact, we have to enhance it and we have to support it more. Those that live in rural communities are not as healthy. And, if we extract more resources from primary care in rural communities, we're going to go in the wrong direction. So I think we've got this important report. We encourage all of you who have joined us this afternoon to take a hard look at it. You will see data at the state level for those of you who are working at the state level. We really intend to continue to work with our federal partners like Alina and others at CMS to continue this conversation about strengthening primary care in rural settings. And we so appreciate you all joining us and look forward to continued conversation. So thank you.